each other, they're roughly the same. So this is 100% nonsense. This is not true. But Dr. Ira Chasnoff, after he saw what he had done, he tried to walk back his claims and he tried to undo that damage. But those headlines just suffers, and it's just not as interesting to talk about how, oh, just kidding, it wasn't as bad as we said. And so since the 80s, which is, 40-ish years ago, we have repeated this over and over. And sometimes it's crack, which, by the way, is identical to powder cocaine. It doesn't matter which is which. So yeah, crack baby, cocaine baby, regular baby, you cannot tell the difference with the naked eye. And so we're left with this. And we see it with all of the substances. We see it with cannabis, with methamphetamine, with opioids, and crack comes back around occasionally. I've also seen really silly things, even some of the less popular substances like salvia. I've seen reports that just mimic this harmful and straight up lies that were perpetuated in the 80s and continue to this day. So we're going to jump back a little bit to the 70s. This is the time when the war on drugs really on its feet. The Nixon era, followed by Reagan, of course, who did a ton of his own damage. And this quote I'm going to read you is from that very angry, chinless gentleman in the center top. His name was John Ehrlichman. He was a top Nixon advisor, and he was one of the architects of the war on people who use drugs. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. And if you think this kind of actions by our leaders is in the past, it's not. This is currently happening now, today, and happening, and we have to push back against it. So hopefully I've established by now, the war on drugs is a war on people of color. Black people and white people use drugs at similar rates. Most studies actually find a slightly increased rate of substance use among white people compared to other people of color. However, it's not necessarily statistically significant. However, Black people are imprisoned for drug charges at 6 times the rates of white people. And for Native Americans, it's even higher, especially Native American women. I believe Native American women are imprisoned at roughly the rate of Black women. When we do our due diligence and we look into these charges, there are tons more exonerations and findings of wrongful imprisonment among Black people. This is intentional, it's systemic, and it's not in the past. It is currently happening now. We know the war on drugs is also a war on women and children, and all of us have intersecting identities. Nobody is just one or just a Black person. So when you have all of these multiple intersecting identities, it's even more difficult to navigate these systems that were specifically and intentionally designed to harm you. We see that the majority of incarcerated women are mothers of minor children. We also know that a large percentage of them, estimates are 3 to 10%, when admitted to prisons and jails, are currently pregnant. Now, this is probably a vast underestimate because most prisons and jails don't test for pregnancy and don't even ask. It's because they don't want to provide prenatal care, because prenatal care is expensive, but that's a whole other talk. We also know that our rates of incarceration as a society in the last 50 years since the beginning of the drug war have skyrocketed. But when we look at women's incarceration rates in particular, they are increasing at double the rate that men's imprisonment is increasing. We also see a bunch of laws that are implemented that blame pregnant people for their pregnancy outcomes. Now, anyone who's ever been pregnant can tell you that it is scary and you are not the boss. We cannot control our pregnancy outcomes. And all of us, of course, want healthy pregnancy outcomes. But regardless of that, roughly 3% of babies born in the United States will be born with some kind of birth defect. Miscarriage affects roughly 6 to 20% of all pregnancies. And those are likely underestimates because many people miscarry before they even know they're pregnant. We also have one of the highest maternal death rates of any so-called industrialized country in the world. So we know that people may have negative outcomes and it just happens sometimes. There is no evidence to support blaming pregnant people for their pregnancy outcomes or holding a pregnant person responsible to produce a healthy baby at the end. These kinds of laws and interventions also create a new class of that can only be committed by someone with the capacity for pregnancy, which makes it automatically gender discriminatory and unconstitutional. So I just want to zoom in a little bit on fetal assault laws. These are laws that have a greater punishment for people who hurt someone who's pregnant. We know that these laws don't work, firstly. I personally have my cousin, sorry, it's hard to talk about, was strangled to death by her partner who she had a restraining order against while she was 37 weeks pregnant, and they both died. These laws don't fix anything. Punishment is not how you fix something. What ends up happening with these laws is that they are frequently used to prosecute people who are suspected of using illicit substances while they are pregnant. So there is one law that is supposedly designed to keep children away from dangerous equipment in drug production labs or meth labs. However, prosecutors define the uterus as a meth lab and use these to prosecute pregnant people. We also see all kinds of wacky stuff. Like there was one woman who was arrested for not wearing a seatbelt while driving while she was pregnant. We see women who are suffering mental health crisis and have suicide attempts prosecuted under these laws. And in some cases, we see charges of murder and decades-long prison sentences, which is common. There are dozens, if not hundreds, of women in prison right now for having a substance use disorder or a mental health problem while pregnant, and is unacceptable. So hopefully this is obvious to most folks on this call, but I just always say it anyway. Threats of arrest or criminalization do not increase a parent's ability to stop using drugs. We know that threats and punishment are ineffective. They stress people out. And what do stressed out people want to do? Drugs. So not only is all of this nonsense just nonsense, but it's also opposed by literally everyone. Every single medical and substance use organization opposes criminalization of substance use during pregnancy. This includes the American College of Obstetricians and Gynecologists. This includes every nursing group, every substance use treatment doctor group. This also includes a very long list of law enforcement and I don't know what the incarceration people call themselves, prison administrators. We also have guidelines saying that no pregnant person who is incarcerated should ever be shackled as they attend prenatal care, during birth, or postpartum. And yet, when I work in these hospitals, that is the norm. I see that everywhere, despite being opposed by the prison medicine industry leaders, I forget their names, despite being opposed by literally everyone who has a position statement about it. The US Marshals are involved there as well. There's a full list at advocatesforpregnantwomen.org, who I strongly recommend that everybody become familiar with. They're amazing. Okay, so Despite all this, despite knowing how to do better, despite just mounds and mounds of research, this is what our drug policy looks like. We arrest people, primarily people of color. We break up families, hurting women, children, and babies. And we have more people dying of overdose than are dying of COVID. And we have medical providers and people like me forced to participate in these carceral systems that operate within our healthcare system. I have a couple slides of data and a couple more things, and then we're gonna get into trauma-informed care. Promise, just had to lay the groundwork for what we're against first. So we know that most substance use occurs during the reproductive years. This slide is from the National Survey on Drug User Health, NSDUH, as I like to call it. I love this data set because it is vast, it's massive, they do it every year, and most of what comes out of it, I'm like, oh, duh. So it's aptly named as well. We also see that when people become pregnant, they dramatically decrease their substance use. So for those on cell phones who can't see, the columns on the left are alcohol use, blue is pre-pregnancy, red first trimester, green second, purple third. The middle is cigarettes, and the last one is illicit substance use. So we know that most people are unaware of pregnancy, at least until partway through the first trimester. So what we're really looking at is those green and purple columns. So we see for alcohol, it goes down dramatically from a little over 50% of people using to about 5%. For cigarettes, we see a little over 20%, and that only goes down by about half, which is pretty consistent with what we know from the literature. Cigarettes are much harder to quit using than any other substance. And then for the illicit ones, we see a gradual decrease from a little over 10% to, I'm estimating, 2 or 3%. So those people that are still using in the second and third trimesters are likely to be diagnosable with a substance use disorder, because we know that when people become pregnant, everybody wants to make healthier choices. It's one of the most unique periods in our lives when we can make positive change, and we have that really strong motivation. I want to quickly acknowledge that every single harm reduction intervention that exists in the world today was conceived, implemented, evaluated, and fought for by people who use drugs, many times risking arrest, risking loss of their jobs, loss of their homes, loss of their children, and we owe them a great gratitude. Without these folks to stand upon whose shoulders we stand, we wouldn't be here today. All right, now we're going to get into it. So there are a couple of very simple but critical concepts that we have for doing trauma-informed care. The first one is any positive change. This is a harm reduction mantra that was popularized by Dan Bigg, shown here doing a Narcan training. If you don't know, Dan Bigg is the reason why Narcan is a household name. Dan Bigg was spreading Narcan back when it was illegal. He is the father of Narcan, as far as I'm concerned. Anyhow, so any positive change, it's so simple, but it's really hard it's a hard concept for service providers to grasp, especially doctors and nurses and healthcare people. We are used to care plans and flow charts, and we are used to deciding what's going to happen with our patient, but that is not what we should be doing. We need to be doing patient-centered care, and that means that we promote any positive change in behavior, in health, in situation, as defined by the patient. So oftentimes we get in there and we're like, oh, you're using heroin, let's tackle that first. But the patient might have other ideas. I worked with one young lady who was using a lot of methamphetamine, and if I had just been like, oh, you need to stop doing that, then we never would have had this conversation. I asked her what her goals were, and she said, well, I have to keep using methamphetamine to stay awake at night, because if I don't have housing, and if I fall asleep outdoors, my stuff will get stolen and I'm raped. So she wanted to work on getting into safe housing first. which we did and was successful. And we know that getting people into housing always dramatically reduces the amount of substances they use, because if you're not cold or hot, alternatively for those of y'all in the Southwest, if you are not afraid for your life, you don't need to protect yourself with the armor of these substances. You don't need to treat your pain with opioids. You don't need to stay awake all night to avoid getting attacked. So it's really important to accept any positive change. Another reason I like this one is because, you know, a relationship with a substance can be, for some people, the most meaningful relationship they have in their life. It can be really scary to be told you have to stop doing the only thing you do that brings you pleasure. And so for a lot of folks, it's important to make small positive changes. Maybe we can work on smoking less cigarettes first before we attack your opioid use. Maybe you can stop biting your nails, or maybe you can work on getting identification so that you can get a job and get into housing. Once people are able to accomplish small goals, the bigger goals seem a lot more doable. Another harm reduction phrase that I love is meeting people where they're at. This can be literally, like in the pictures, that's dance safe. They go out to raves and festivals. They do drug testing. They do education. They help people who get overamped. And then this is my bud, Chris, Abe, in a parking garage. So this means we go to where people are physically, but also emotionally and mentally. So that means if somebody that you work with, one of your colleagues, is really angry at people who use drugs and is taking it out on their patient, but maybe that comes from a parent or a family member who abused or neglected them as a child and also used substances. We can meet people in those spaces and we can hold space to talk about that. And this acknowledges that no matter where you are in your substance use, in your journey as a clinician, we know that all of us are here because we want to do good. We want to improve outcomes. We want healthier people, healthier families, and healthier communities. And we can all meet at that point and then go from there. So when we're talking about trauma-informed care, the basic definition is care that anticipates and responds to the impacts of trauma. We're emphasizing safety, physical, emotional, and psychological. And part of emphasizing safety is promoting autonomy, because one of the shared experiences of everybody who has experienced trauma is a feeling of being out of control. Whether it's war or disease or losing a loved one or experiencing child abuse or assault, we're not in control in those situations. And that can be really triggering for a lot of folks. So making sure that we provide space for people to direct their own care and lead their own care can be very healing in and of itself. When we're talking about trauma-informed, we always have to start with language. Now, language is always evolving and there are always new words, but the most important thing isn't to be right. The most important thing is to be thoughtful and intentional. So choose language that is value neutral. If you're talking to somebody about what's going to happen, use the word effects rather than consequences. They mean almost the same thing, except effects doesn't come with that judgment, which people don't need and is not helpful. I like to use a person with substance use disorder or person with opioid use disorder, which is consistent with the DSM-5, which is the Diagnostic and Statistical Manual, which we use for mental health stuff. Person who injects drugs. We don't use the word addiction or addict, because it doesn't mean anything anymore. It means 1,000 different things to 1,000 different people. And it has also been identified as hate speech by people who use drugs. I want to be clear, if somebody chooses one of these words for themselves, then they should be allowed to do that. We are not out here trying to correct people who feel that they want to call themselves an addict. But we as service providers, friends, family members, and clinicians, we don't put those negative words onto other people. When we're talking about babies, we talk about prenatal substance exposure or physiological dependence. Babies are not addicts, they are not drug babies. They are babies who are experiencing a medical condition. just like any other. When we're talking about treatment, my favorite term is opioid agonist treatment, or OAT. Agonist means, so like we all know about like the brain receptor and the key and lock theory. An agonist is something that fits in the lock and turns on the receptor. So that's why I prefer this term, because these are the best practice medications for pregnant people with opioid use disorder. MOUD, or medications for opioid use disorder, also includes non-opioid agonist medications such as naltrexone, which is not recommended as a first line for people with opioid use in pregnancy. Naltrexone is the opposite of an agonist. So rather than a key that turns on the lock, it's like shoving gum in the lock, so that nobody can open it and that it stays off. These other terms are like way old, and I hope that we are not using them anymore. They can be problematic because methadone replacement therapy suggests that, as some detractors say, they're just one addiction for another, which is 100% untrue, and I will fight you. There's dozens of studies, so let me know if you would like to have some information on that. Medication-assisted treatment I don't like, because this puts opioid use into a whole other category. Like, we don't say someone with diabetes is getting insulin-assisted treatment. We know that diabetes treatment contains a whole range of lifestyle, nutrition, various medications, counseling, but we don't talk about it like that. It also suggests that medications alone are not effective, which they are. Obviously, we want to offer people as many adjunct therapies as possible, but these medications by themselves are the #1 best treatment for anyone, including pregnant people. We also want to be gender inclusive. People of all genders can get pregnant, parent, and feed their babies. I like to say what I mean and be precise. So when I'm talking about people who can become pregnant, I say people who can become pregnant, which includes cisgender women, some transgender men, and many non-binary folks like myself. We also need to use different language for families, for body part. If you're not what language you use, ask. People appreciate that. It's also really important to remember that many people have experienced trauma, abuse, and violence at the hands of healthcare providers. This is rampant, common among people who are marginalized and oppressed, which includes women and people who use drugs. So for most of our folks, asking for help is really scary, and they need to be affirmed and made to feel safe for that. So the #1 intervention in trauma-informed care, if you leave with nothing else today, please leave with this. The most important intervention is to foster spaces and therapeutic relationships. Because if you don't do this, they won't come back. A big one is trauma care is that you do not need to know the details of everyone's trauma. Oftentimes when I attend sessions like this, people encourage providers to ask patients to tell them their traumas. This is not a good idea. Firstly, when you're moving through the healthcare system, you're talking to dozens and dozens of people, sometimes in the same day. And if you are asked to retell, which means relive your trauma with each person, that can be just incredibly re-traumatizing, and even I would consider a form of abuse. So you do not need to ask patients for details. Trauma-informed care is about assuming that many of our patients have experienced trauma and doing our best to address that trauma without reactivating it. So it's important to let clients know that you're there to listen if, when, and how they want to share, but no pressure. So some steps. We'll just go through some strategies real quick, and then hopefully we'll have a little time for questions. Step #1 is acknowledge your patients for showing up, because it is scary. It can be as simple as, welcome, I'm so glad you're here. When I work in the NICU, I tell the parents, oh, your baby's going to be so happy to see you. Or if they call, I say, I'm going to tell your baby you called, because they'll be so happy to hear it. Those little things can make all the difference in the world to somebody. we need to reframe the way we address certain behaviors. Non-compliance is my least favorite word in all of medicine because it's garbage, it's BS. When our patients do not follow the care plans of care that we have pushed on them, that's because they either are unable to or don't agree. They're protecting themselves. Attention seeking, like, isn't that what we're here for? When people come to the ER or they come and seek medical care, they are seeking attention. And if they do it in a way that doesn't feel good to you, then you need to just grow up and be the provider and let our patients be the ones that are in a crisis. And if we don't like their tone or they're being too dramatic, then we need to just, that's a you problem. That's not a patient problem. Pain without an obvious cause is a big one. I once had a patient and she was having chest pain in the postpartum period. And I did all the things. We did a cardiac workup and a pulmonary workup and an infectious disease workup. And finally, I was a younger nurse then, less experienced than I am now. Finally, I had a psychologist come up and talk to her, and it turns out that she had been raped, and all of the people seeing and touching her body had triggered that response. And so this is a really common theme for people who experience trauma, because oftentimes when it's too scary to look at and our emotional pain is so overwhelming, our body will translate that into some kind of physical pain. So it's really important to keep an eye out for those kinds of reports. It's equally important not to assume that all pain reported by women is in our heads. So strike that balance there. Lashing out is another one. This is a way of patients protecting themselves. I see this especially with male patients, dads of my NICU babies a lot. When you are being threatened, as our healthcare system does to so many of our patients, this is a natural reaction to protect yourself. I ask the parents in the audience right now, if somebody came to you and told you that they were going to take your kid away, you would fight back. You would lash out too. This is a natural and expected response to these situations. So again, when our patients behave in ways that feel uncomfortable to us, we need to be the healthcare provider and the professional in the situation and provide a safe landing place for all of those really scary and complicated emotions. Inconsistent narratives is another one that's really common for people with trauma experience, because one of the hallmark symptoms of PTSD or experience of trauma is jumbled up memories. You remember things in the wrong order. Some days you remember it this way, some days you remember it that way. And it's really hard to give the same story multiple times. So if we see inconsistent narratives, it's not our patients being manipulative or trying to get something. It is simply a normal and expected trauma response. A couple concepts that we're going to talk about real quick before we get to questions. Unconditional positive regard. This is basically being nice to and respecting your patient regardless of what happens. The definition from 1957, which is in old-fashioned language, it means caring for the client, but not in a possessive way or in such a way as to simply satisfy the therapist's own needs. So when we react to people in ways that are meant to make us feel comfortable and to satisfy our needs or to get through our day quicker, this is not unconditional positive regard. We have to care for the client as a separate person with permission to have their own feelings, their own experiences, and I would add their own ideas of how to prioritize their health and how to improve their health. So in practice, this looks like unconditional positive regard. I mean, it's right there in the title. Respecting people's decisions, thanking them for sharing with us, and letting them know they are the best person to make decisions. Remaining available to our clients. I hate it when I hear about providers firing a patient because they don't want to plan or they disagree with you. They're not there to agree with you. You're the person that's getting paid to do this care. So your job is to be there for that person and to support them. If they pick a plan that is a terrible plan, that's their plan. And on down the road, if it doesn't work, then you're there for them and you help them make a new plan that might work better. Trauma-informed care is also motivational interviewing. This is a style of conversations that I have found is helpful with everyone in my life, from the lady to my family members to my patients. So you're not telling people what to do. You're not making judgments, threat, ultimatums. You're asking open-ended questions and helping the client come to their own conclusion. Because from the last slide, we know that people want what's best for themselves and their families. We're also asking permission before we offer advice or information, because we all know it. I mean, it's like a relationship trope even. Like sometimes you just need to listen and people are not asking you for your opinion. And so this can be really effective for clients as well. So what this looks like is asking, what do you think about this? What do you want to do? What has worked for you before? Because most people have tried lots of stuff before they arrive in our clinic or in our space. It's also reflecting. It sounds like you have conflicting feelings about your alcohol dependence now that you're pregnant. Let's talk about that a little bit. SBIRT is screening, brief intervention, and referral to treatment. It's important to note that screening does not mean screening of body fluids. This is conversations. So use a validated tool to start the conversation. And remember that no matter what the tool says, the patient's own perception of their substance use is what is most important. Brief intervention, ask what you can do to help right now, right this minute. Do you need medication? Do you need baby clothes? Do you need formula? What can I do? And then with permission, make referrals to providers that you can trust. And I have some links to validated tools in the end. Oh my gosh, 5 minutes. I made it. Questions? I see a few in the chat. Should all intrauterine exposed newborns be considered a harm event? No. I would say that no intrauterine exposed newborns should be considered a harm event. This, if a baby has been harmed, then there will be some evidence of harm. What is in your parent's urine or what is in your blood or your body is not evidence of harm. It's just evidence of exposure. Let's see. I'm pulling up the chat. Reagan, let me know if there are any themes that you've seen. I'm going to start scrolling.
Sure.
Yeah, firing patients who use substances. It's like I have a substance use disorder and I'm asking for help, and then I am not immediately successful at curing my substance use disorder. So you fire me for having the disorder for which I am seeking your help. It's bizarre. It's bonkers. It makes me so angry.
I think there was a point earlier in the chat about how the criminalization of substance use during pregnancy is directly related to the criminalization of HIV for pregnant women and
yes.
pregnant folks and folks who aren't pregnant. Could you speak a little bit to your experience as a clinician with criminalization of HIV?
I have very rarely taken care of a patient who's positive for HIV. However, I can say that all criminalization is intersectional. And most of it, I'm going to say all of it. Criminalization does not fix any problems. Criminalizing people for having an illness doesn't treat that illness. It doesn't prevent that illness. All it does is drive people underground. It discourages people from getting tested, and it discourages people from getting treatment. When we have pregnant people with HIV, we know that worldwide, I believe, I'm pulling these numbers off the top of my head, roughly 10% pass HIV vertical transmission from the pregnant person to the baby. But with treatment, we can get those numbers down to 1%. So it's so important to decriminalize and also destigmatize HIV infection, because all we're doing is discouraging people from getting tested and discouraging people from seeking help, which is amplifying the problem. Yeah, they totally did. They defined, I'm responding to Stephanie in the chat multiple times, actually. I want to say it was Tennessee or Alabama, but they used a law that it was like called the meth lab law or something, to prosecute multiple pregnant people for using methamphetamine while pregnant. And yeah, they in court defined the uterus as a meth lab. There are also lots of prosecutions against pregnant people and parents who for laws about delivering controlled substances to a minor, and they consider the umbilical cord in the seconds to minutes after birth as a avenue of substance delivery from an adult to a minor, which is, it's just absurd the way these prosecutors are bending these laws and using them in ways that they were never intended to be used. And the reason that this happens is because prosecutors have all the power. When you are going after somebody who our society has stigmatized and vilified and pushed to the side and isolated and tried not to look at, it's easy. And so we need to stand up for these folks, and we need to tell people their rights, and we need to tell our patients, you don't have to stand for that. You don't deserve it. And it's not, so I've gotten in trouble. I've occasionally told my patients, oh, what the hospital is doing to you is not okay. And if you fight them in court, you will 100% win, and I will stand up with you. And that is probably why I've been fired twice. Yep, Clarence Thomas wants to criminalize pregnant people. He said so right out loud. So it's been really hard on this for me not to swear. But I will just gently say, screw Clarence Thomas. Oh, somebody made a comment about perinatal loss. Mothers are often blame themselves for the loss. I will say, in every perinatal loss I've ever experienced, in every NICU mom, they always blame themselves. We do not need to contribute to that. It is unhelpful and it is untrue. I have a dear friend who lost a baby, and she had, when she was in the NICU, her baby survived for hours before passing. Everybody was so compassionate and said, it's not your fault, these things happen, we don't really know why. But the moment somebody uses a substance, that goes away. And healthcare providers will say, this is your fault, you deserve this, how could you? And that just, my heart that happens. Faced with these huge systems, how do you take care of yourself? How do you maintain this level of energy and compassion? I cry a lot. I'm gonna cry right now. So it's really hard to leave work at work, and I also don't all the way want to. I think the day that I am no longer brought to tears by the way our healthcare system treats pregnant people who use substances is the day that I need to retire and get out of the field. Because our patients deserve people who can feel something and who are soft. And it's really hard and really uncomfortable. But I cry a lot during my presentations, and I always say I'm not ashamed of it. I am proud that I have been able to maintain softness and compassion, because that's what our patients deserve. I will say the interruptingcriminalization.com is a wonderful resource. We on November 3rd, we are releasing our Beyond Dunham Harm principles, which are in healthcare, and that's going to include some tips and information about how to protect both emotionally, but also how to push back from inside these systems while protecting your livelihood and your job. Yeah, probably not the answer you were looking for. Yeah, they always get mad that I like care about and advocate for my patients, but I'm like, you guys, that's our job. Our code of ethics, doctors, nurses, social workers, every single one I've ever looked at says our job to advocate for our patients, not for our employers, not for our healthcare systems, not for the facility that we work for. Our job is to advocate for our patients as defined by what they want. Yes, ableism is all throughout this. I wish we had more time to talk about that. Absolutely. Ableism and a lack of tolerance for typical neurology as well. Oh yeah, yeah. I love bringing up the ethics stuff. I mean, it doesn't really have any teeth. Nobody is enforcing it, but yeah, people are violating their ethics codes and their licenses. But that's a whole other, licensing boards are a whole other thing that we can't get into. I'm trying to keep track of the Q&A and the chat. Okay. There's a question about, do I have social media? Yes, but that was involved in one of the time. So I can support myself full time with this work, I'm going to have to hold back publicly. I would love to be able to let loose. I will say I have a YouTube channel that I will pull up the link to right now, or try to. And my first YouTube video ever is my very favorite, and I don't hold back. And I yell at the organizers of the event that I am currently speaking at. So there's the YouTube channel. It's called Drug Bigotry, and it's the first video on there. We have tons of our presentations and stuff on there. But yeah, social media is something that employers look at. And so I have to be really careful about what I say and do in public. But I think we're like 5 minutes over. So I think we will have to stop. And thank you, Megan. Thank you for sharing in there as well. It was really nice to see you and every peer. Please feel free to reach out to me. I love corresponding with people. I would love to work with any and all of you in the future as well. Okay.
Thank you. I didn't want to cut you off because you were on such an amazing role, and also I was choked up. So like I would have only interrupted with like a strained voice from starting to cry. But thank you so much, Joelle. Thank you everyone for joining. We hope to see you next week for our conversation on mandated reporting laws and how clinicians can push back against them for the benefit of their patients. So thank you so much, everyone. We'll see you next week.
All right. Bye-bye. Thanks, everyone.